Hello, everyone. Good morning, good afternoon, and good evening. We have a truly global audience today. Welcome to today's session, and thank you for taking the time from your schedule to be with us today. My name is Filomena Gonçalves. I'm Senior International Marketing Manager at Natus Medical, and I will be your host for today. With me, I have Simone Poggi, who leads our clinical applications team. Before we get started, I would like to go over a few organizational items so you know how to participate in today's event. Now that you have joined, you will notice that you are on mute. This will allow us to manage background noise during the presentation and ensure that you have a good experience. We will allow time for questions at the end of the presentation. Please type in your questions into the question box on your screen. You can open the question box by clicking the white arrow or the question mark in the control box. You may submit your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. This meeting is going to be recorded and it will be available for viewing at a later date at the Neuro Training Academy website. And today's session is entitled Epileptic Seizures Part 1, the new International League Against Epilepsy Seizures Classifications Pragmatically Explained. This is the first part of two webinars on seizure classification. And it is my pleasure to introduce our guest speaker for today, Professor Sándor Baninsky. Sándor Baninsky is a board-certified neurologist, clinical neurophysiologist, and epileptologist. He is professor at Aarhus University Hospital, and he is the head of the clinical neurophysiology department at the Danish Epilepsy Center. He is the chair of the Joint EEG Task Force of the International Federation of Clinical Neurophysiology and the International League Against Epilepsy. He is also a member of the International League Against Epilepsy Commission on Diagnostic Methods, International League Against Epilepsy Education Council, and the Executive Committee of International League Against Epilepsy Europe. He is editor-in-chief of Epileptic Disorders. The main research interest of Dr. Baninsky is EEG in epilepsy, focusing on electromagnetic source imaging, seizure detection, standardization, and quality assurance in clinical neurophysiology. He has supervised 8 PhD students and is the author of 133 peer-reviewed papers and 21 book chapters. Professor Baninsky, the floor is yours.
Thank you so much for the nice introduction, Filomena. Welcome to this webinar on seizure semiology and EEG and the new seizure classification. I would like to start by expressing my gratitude to Natus for organizing all this. And now I will switch to my presentation. I'm going to talk about seizure classification, and I will show you video examples and EEG examples of all seizure types. I will do this because you cannot learn about seizures just by reading in a book. You really need to see the examples. This is the outline of my presentation. I will start with a brief historical note. Then I will give you an overview. I will show you the list of all seizure types. Then today I will show examples of generalized seizures, and this will conclude the first part on seizure classification. And then next time I will show you the focal seizures. So most of you, when you did your training, you learned the classification that was issued in 1981 by the International League Against Epilepsy, although some of you might be familiar with even older terminology like petit mal and grand mal. But in 1981, the ILAE issued this classification and these terms. So there were the partial seizures, which were the equivalent for the focal seizures, and then they distinguished simple partial seizures without disturbance of consciousness and complex partial seizures with disturbance of consciousness. And then if the ictal activity propagated to the contralateral hemisphere, then you could evolve to generalized tonic-clonic convulsions. And then there was the long list of generalized seizures with all types of absences and motor seizures. We will talk about that later. Now, the theory was that the thalamus was like a conductor synchronizing all the activity in the cortex. So this was the concept of the generalized seizures. In 2010, the ILAE Commission on Classification and Terminology revised the definition of the epileptic seizures. There was a paradigm change. Now, generalized epileptic seizures are conceptualized as originating at some point within and rapidly engaging bilaterally distributed networks. Such bilateral networks can include cortical and subcortical structures. We know the role of the thalamus in maintaining the corticothalamic oscillations during the generalized seizures, but do not necessarily include the entire cortex. Individual seizure onsets can appear localized, and generalized seizures can be asymmetric. So the infographic to the right illustrates this paradigm change. So it's not any longer the whole cortex that is synchronized by the thalamus, but we conceptualize generalized seizures as large bilateral networks where the ictal activity can start at different points, but then it rapidly propagates and engages the whole network. And then the focal seizures were redefined too. So the definition said that these were conceptualized as originating within networks limited to one hemisphere. They may be discretely localized or more widely distributed. Focal seizures may originate in subcortical structures, like we know the hypothalamic hamartoma or the periventricular nodular heterotopias. For each seizure type, ictal onset is consistent from one seizure to another with preferential propagation patterns that can involve the contralateral hemisphere. In some cases, however, there is more than one network and more than one seizure type, but each individual seizure type has a consistent site of onset. So again, the paradigm shift was from this concept of partial volume full of epileptic activity to this more restricted network. So again, this was the old concept in this infographic, and this is the new one. So big bilateral networks with rapid propagation for generalized and the restricted focal network for the focal seizures. Then in 2017, the International League Against Epilepsy issued a new operational classification of the seizure types, and this is what I'm going to focus on today. So the new classification defines the focal onset seizures, the generalized onset seizures, and then of course some are unknown, or if we don't have enough information, then they are unclassified. Now, within the focal onset, you distinguish those that are aware and those that are with impaired awareness. And then we have motor onset, non-motor onset, and the old term of secondarily generalized tonic-clonic seizure or focal seizure evolving to generalized tonic-clonic seizure. That was changed. So the new name is focal to bilateral tonic-clonic seizure. Now, the generalized onset seizures can be motor, or there is a long list of absence seizure types. And this is what I'm going to show you today. So we will start with the motor generalized seizures. I will start in the order of increasing duration of the motor seizure type. So I will start with the shortest generalized motor seizure, and this is a myoclonic seizure. I will start by showing the video, the EEG, and then the video. So this is in a common average montage, and then the two channels at the bottom in green line. These are surface electromyography recordings. So you can see this very, very short activation, like as if you just stimulated the patient with an electrical pulse. This is the myoclonic seizure. So the duration of the myoclonic seizure is up to 0.1 second, up to 100 milliseconds. And this is the same in a longitudinal bipolar montage. Now I'm going to play the video. So please note that there will be a very short jerk, bilateral, symmetric, the generalized myoclonic seizure. And then the second movement will be a reactive movement. So the patient is also scared by the spontaneously occurring seizure. This was the myoclonic seizure. This was the myoclonic jerk. So let me play that again. Yes, so that was the seizure. So the shortest generalized motor seizure, that was the myoclonic seizure. Now, a rhythmic repetition of a generalized myoclonic seizure is a clonic seizure. So clonic seizure is a rhythmic myoclonus at around 3 Hertz, 3 cycles per second. Again, here you can see the EEG in a common average montage. You can see the bilateral synchronous spike and slow wave discharges around 3 Hertz. And now at the bottom, you can see the green electromyography channels. And you can see that each spike and slow wave has a time-logged jerk. So spike and slow wave, jerk, spike and slow wave, myoclonic jerk. So this rhythmic repetition of the myoclonic jerks around 3 Hertz is a clonic seizure. So this is in a common average montage, and then you can see the same with the phase reversal in the bipolar montage. Now let me show you the video. Please observe the bilateral symmetrical, so generalized rhythmic repetition around 3 Hertz of these myoclonic jerks. So the rhythmic repetitive myoclonic jerks constitute the clonic seizure. Okay, so we said that the duration of the myoclonus is up to 0.1 second. Now we will see a longer motor seizure, an epileptic spasm. This was earlier known as infantile spasm. The new name is epileptic spasm. I will show you a generalized epileptic spasm, but please keep in mind that you can see also asymmetric or focal epileptic spasms too. Now, the duration of an epileptic spasm is between 0.5 seconds and 2 seconds. The EMG pattern, the surface electromyography pattern, is very typical. So you can see here at the bottom in the green surface EMG channels, you can see this diamond shape. Now the spasms typically occur in clusters. And then as here you can have high frequency, low amplitude activity as the ictal correlate, or you can have generalized electrodecremental response, a flattening, or you can have a giant slow wave as EEG correlate. Now the movement pattern, the gestalt of the epileptic spasm is typical. So you have a flexion, rarely an extension, but more often a flexion in the axial muscles, so a flexion in the neck. And in the same time, you have an abduction in the shoulder and the flexion in the hip. So again, this is the seizure in common montage. and here you can see the same in the bipolar montage. And keep in mind that the EMG is very typical. So again, please note the specific movement pattern with the flexion in the head, abduction in the shoulder, and flexion in the hip. And as I said, they occur in clusters. So if we wait, then we see more. So these are the epileptic spasms with a duration between 0.5 and 2 seconds, and they occur in clusters. Now even longer, so now we are 3 seconds plus, most often 3 to 15 seconds. So tonic seizures. They can start differently. So some of them can start abruptly. As you can see here, the tonic muscle activation starting abruptly. And then here you can see the EEG correlate, this time as paroxysmal fast activity or run of rapid spikes, generalized. You could have also electrodecremental response as EEG correlate. So this is a tonic seizure that starts abruptly. You can see here the same EEG pattern in a longitudinal bipolar montage. And here comes the video. Please observe the tonic muscle activation, the tonic stiffening bilaterally, and in this case the tonic seizure starts abruptly. Tonic seizures can have also a vibratory component superimposed, and often this is misdiagnosed as a tonic-clonic seizure. So this is not a clonic phase. This is just a superposition of a 10 Hz vibratory component on the tonic phase. So let me show you an example of this. So the EEG starts with an electrodecrement, and then you can see the gradual build-up of the tonic muscle activation. The same here in longitudinal bipolar montage. Now I have compressed the EEG more so you can see the gradual build-up of the tonic muscle activation and then the gradual decrease of it. So here's the gradual start. Gradual build up of the tonic muscle activation, and then look at these small vibratory movements that are superimposed. Look at the lower limb. Here you can see the vibration that are superimposed. So this is a tonic seizure, and these are just vibratory movements, and this is not a clonic phase. Tonic seizures can be very discrete motor phenomena. Let me show you an example. So look at the head of the patient, and now you can see a tonic movement, but this would go unnoticed. So it's very useful to have surface electromyography, because here you can beautifully see the tonic seizure. The EEG correlate is very nice. Also, you can see the pre-ictal spike and slow wave, then the electrodecremental response, and then you can see beautifully how the low amplitude fast activity is evolving from it. You can see that the amplitude gradually increases and the frequency gradually decreases. So this is a beautiful EEG example, and then you clearly can see also the tonic component on the surface electromyography. This is the same in a longitudinal bipolar montage. So again, the pre-ictal spike and slow wave, the electrodecrement, and then the beautifully evolving ictal activity. Now, during seizures, we have also negative phenomena, so not just positive like myoclonus or clonic seizure, but we also have negative phenomena, so the normal things disappear. For the focal seizures, we will see ictal palsy and aphasia. Now here for the generalized seizures, I would like you to learn the atonic seizure. Clearly see what it is, just as in this case. So no activation in the flexors and inactivation in the extensors of the neck. So this was an atonic seizure. Now this brings us up to the, if I may say so, the most dangerous seizure type. This is the generalized tonic-clonic seizure. This has the highest risk for injuries, and also this is the highest risk factor for sudden unexpected death in epilepsy patients. Now let's start with the EEG. Again, in a common average montage, you can beautifully see the bilateral synchronous ictal activity, which nicely evolves. So first, actually, the amplitude goes down and the frequency up. It's almost like an electrodecrement, but of course, if you zoom at it, the electrodecrement consists of high frequency, low amplitude activity, and then this evolves again. So beautiful generalized ictal EEG signal. And then here in the EMG, you can see how the tonic muscle activity gradually builds up. Do the same in longitudinal bipolar montage. And here I focus just on the surface electromyography signals. This is compressed so that you can evaluate the whole seizure duration. Here you can see the gradual buildup of the muscle activity, and then the tonic muscle activity is interrupted, inhibited by longer and longer periods that we call silent period. Now, this is the mechanism that eventually stops the seizure. So the silent period become longer and longer. This gives you the clonic phase. So in a generalized tonic-clonic seizure, the clonic phase is generated by longer and longer inhibition of the tonic muscle activity. And here comes the seizure. Please observe at the beginning of the seizure the so-called ictal cry. That is caused by the contraction of the diaphragm, which pushes the air against the larynx, giving this very characteristic noise. Then observe the gradual build-up of the tonic muscle activation, the tonic stiffening. And the clonic phase starts now, so please observe the clonic jerks with a gradual decrease in the frequency because of the longer and longer inhibitory phases. The longer and longer silent periods interrupt the tonic muscle activation, eventually stopping the seizure. Now there are several other combinations of generalized motor seizures. I will show you a myoclonic-tonic seizure. So here on the EMG channel, you can see this green upswing. This is a myoclonus, and then this is followed by a tonic muscle activity. Here you can see artifacts and then an electrodecremental response during the phase. Let me show you just the EMG. So again, this upswing, this is the myoclonus, and then it is followed by the tonic phase. So please note the myoclonus at the beginning. that was the myoclonus, and this is followed by the tonic muscle. Let me play it again. Oh, that was the myoclonus, and then followed by the tonic seizure. So myoclonic-tonic seizure. Another seizure type is the myoclonic-atonic seizure. So here you can see the common average montage and then the EMG channel, again the myoclonus, and then during the electrodecrement you have the cessation of the EMG activity, which gives you the atonic phase. Again, here is the electrodecrement in a bipolar montage. Okay, so please note the brief jerk at the beginning and then the atonic phase. The atonic phase, as I showed you on the surface EMG electrodes. Now, another combination is the myoclonic-tonic-clonic seizure. We see this quite often in patients with juvenile myoclonic epilepsy. Let me start by showing you the EEG again. So I compress the EEG so that you can assess better the dynamic evolution in this process. So you can see it starts with around 3.5 hertz spike, polyspike, and slow wave discharges. And then in the EMG, you can see the jerks. And then here you can see the tonic phase of the following generalized tonic-clonic seizure. Now, another interesting thing in this recording is that you can see actually an evolving ictal rhythm here in the right frontal area. So this is asymmetric. Now, please remember what I told you related to the new definition of the generalized seizures. So they can start focally. And here's the same in a bipolar montage with the 3.5 hertz spike, polyspike, and slow wave discharges, and then the evolving ictal rhythm in the right frontal area, and then the generalized tonic-clonic seizure. So it's in the morning, it's at the breakfast table, again typical. Now you can see the myoclonic jerks. Those were the myoclonic jerks preceding the generalized tonic-clonic seizure. And then corresponding to this ictal activity that we've seen in the right frontal area, now you can see a version to the left. So please remember that these focal features may appear also in generalized tonic-clonic seizures. Now you can see the phase asymmetry at the start, again a focal feature, and then this continues with a symmetric bilateral tonic phase of the generalized tonic-clonic seizure. And then again, please note that the tonic activity is interrupted for longer and longer periods, and then this gives the clonic phase which gradually slows down. So this was a myoclonic-tonic-clonic seizure. So you've seen the myoclonic jerks in the beginning, and then the tonic-clonic phase. And you've also seen that a patient with generalized epilepsy, she has juvenile myoclonic epilepsy. So a patient with generalized epilepsy can have seizures that start focally or have focal components too. Now we'll continue with the list of absence seizures. And we will start with the typical absence seizures, which you often see in childhood absence epilepsy or juvenile myoclonic or juvenile absence epilepsy. So the EEG is very typical. So you have this very regular, rhythmic, bilateral, synchronous spike and slow wave discharges, 3 hertz, maximum frontally. You can see this in common average montage, and you can see the same in a longitudinal bipolar montage. So bilateral, synchronous, 3 hertz spike and slow waves. Now this is often triggered by hyperventilation. We use this windmill, which is a useful procedure. You can also note immediately if the patient has a motor or behavioral arrest. Now, I would like you to note several aspects. So first, the patient stops hyperventilating, but then the patient will have also discrete gestural automatisms. This is absolutely normal for typical absence seizure. You can see either generalized, either gestural automatisms, or you can also see discrete oroalimentary automatism. This is absolutely compatible. This is part of the typical absence. So you can see the windmill is moving. She's hyperventilating. And then she stops hyperventilating, not repeating the test words that are given, and then she has some discrete interactive gestural automatisms there. Now, she follows commands after the spike and slow wave stops. So they usually continue the activity they were doing before immediately as the spike and slow wave burst stops. Now, another seizure type is the atypical absence seizure. So the prognosis is different, the syndromic background is different. You can see this often in children with Lennox-Gastaut syndrome. So you can see that the EEG is completely different. The spike and slow waves are rather sharp and slow waves. It's slower, it's around 2 Hz, but it's still bilateral synchronous generalized. The other thing that you immediately note is that the activity is fragmented. So the EEG picture is always different between the typical and the atypical absence. Now, if you are lucky, from a diagnostic point of view lucky, then you can also catch semiologic features that can distinguish between typical and atypical absence. For example, the seizure is longer than 30 seconds, then it's atypical. Or you have a pronounced atonic phenomenon like a head drop, not just a small discrete head retropulsion, but you have a full-blown head drop. That's something that indicates an atypical absence. Now you can see the same in longitudinal bipolar montage, so fragmented, irregular, and slower. Now you will see that just the clinical part resembles very much the typical absence. So you will see that the patient stops the activity and will have some discrete gestural automatisms. So the semiology can resemble typical absence, but the EEG is always different. And then she continues with the activity that she was doing before the seizure started. So another seizure that is grouped under the absence seizures is the myoclonic absence seizure. Now, of course, the patient stops with the activity that he or she was doing, so there is a motor and behavioral arrest, but there is a full-blown, very obvious motor component in this absence seizure. There is a specific gestalt, a specific movement pattern. So you will see there is a tonic abduction of the shoulders and then 3 Hz superimposed jerks on this tonic elevation of the arm. Let's start with the EEG. So again, in a common average montage, you can see the bilateral, synchronous spike and slow wave discharges with a frequency around 3 Hz. Now, time locked to each spike and wave, you can see the jerks that are superimposed on the tonic muscle activation. So these two channels were left and right deltoid muscles. And here you can see the same, so bilateral synchronous spike and slow waves in longitudinal bipolar montage, and of course the same EMG picture. So please note that the patient is stopping the activity, he gets a motor arrest, and then look at this very specific pattern of motor phenomenon. So the elevation, the abduction in the shoulders, and the superimposed jerks at 3 Hertz.
Er det frokosttid? Ah, det var lidt for tidligt. Prøv at tage telefonen op på benet.
Now the seizure starts. Flexion in the neck, abduction in the shoulder, and then the superimposed 3 Hertz.
Sol.
Yeah. So this was a myoclonic absence. Another seizure type that belongs to this group is the so-called eyelid myoclonia, which can occur with or without absence. Usually, patients are photosensitive. They respond, the absence responds very well to the therapy, but the myoclonic component is very difficult, almost impossible to get rid of. So you will see that the rapid eye blink, bilateral synchronous eye blink around 4-5 Hertz is the hallmark of this seizure type. The absence is there, but it's short. You will see that this has also an eye closure sensitivity. So in the common average, you can see here the eye blink, the eye closure artifact. And then just after the eye closure, you can see the emergence of this rapid polyspike and slow wave activity. So the frequency is higher than during the absence seizures, and then corresponding to each spike, polyspike, and wave discharge, you have an eye blink and also a tonic deviation of the eyes upwards. The patient will stop speaking for a split of a second, but that's not the most characteristic component of the seizure. Focus on the eye blink. So again, the EEG with the polyspike and slow waves, you can see the same in a longitudinal biplane. And here comes the video. Please observe that the patient will stop for a split of the second speaking, that's the absence in it. But then look at the eyes, that's the hallmark of this seizure. So look at the rapid, repetitive 5 Hertz eye blinks.
Jamen det er det, jeg gør. Jeg kan huske, da vi flyttede.
Now.
Nu?
Ja, det kan men der er jo ikke mere lydholdning, det kan du bare lave hurtigt.
Ja, men det...
Let me play it again.
Jamen det er det, jeg gør. Jeg kan huske, da vi flyttede.
Now.
Det kan du
Nu?
Ja, det kan men der er jo ikke mere lydholdning, det kan du bare lave hurtigt.
Ja, men det...
Show you this in another patient. So look at the eyes. Rapid blink and eye deviation upwards. Okay, let me show you again. So rapid eye blinks, eyelid myoclonic jerks, and eye deviation upwards. So this concludes the first part of the seizure classification. I have showed you the generalized seizures. Next time, on November 3rd, I will show you many examples.
Thank you, Professor Baninsky, for this wonderful presentation. We are now going to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit questions through the question box in your attendee control panel. So I'm going to actually hand it over to my colleague Simone for the first question.
Professor, again, thank you very much for your excellent presentation. We are receiving a lot of questions, so thank you very much for answering. I will start with this one. Will focal myoclonic discharges have a bilateral EEG changes or unilateral EEG changes?
Yeah, I assume you meant focal myoclonic seizure, because discharge, that's an EEG equivalent. So yes, if you record focal myoclonic seizure, then if you can record an EEG correlate at all, then the EEG correlate will be also focal. So focal seizure, focal EEG discharge.
Very clear, and thank you very much. I will go on with the other one that has received several different questions related to the same topic. Are the EMG channels recorded from the same locations for all the studies? And if so, where? Or if the locations are different, how are those locations determined?
Right. Well, we have hundreds of muscles on the body, so definitely you cannot sample them all during a video EEG monitoring. So what we do is we read in the referral what the probable semiology would be, and then we tailor the position of the surface electromyography electrodes for the specific seizure semiology. Now, during the monitoring, if we can see that actually the semiology is different, then we can adjust the position of the surface EMG electrodes. It's very easy. You just need to put 2 electrodes on the muscle you want to examine. Usually it's on the belly of the muscle where you put the active electrode, and then nearby at as neutral as possible point, you put the reference electrode. We like to sample bilaterally, symmetrically. And then I would like to recommend you read the paper issued by the International Federation of Clinical Neurophysiology. So 2 years ago, the IFCN issued a new guideline about the EEG electrode array. And that guideline paper has also an appendix where we suggest where to put your surface electromyography electrode. So the EEG array guideline also contains information where to put the EMG electrodes. Now, my favorite muscle is the deltoid muscle. And then if we don't get many details about the seizure semiology, what I usually start is bilateral deltoid muscle, biceps muscle, and then either anterior tibial or quadriceps muscles.
Thank you very much, Professor. I will go to Filomena.
Okay, so we are actually receiving a lot of questions, which is wonderful. So there is another question for you, and it is temporal lobe epilepsy and complex partial seizures one and the same thing?
No, actually, you're mixing 2 things. You're mixing an epilepsy type with a seizure type. So temporal lobe epilepsy, that would be the type of epilepsy, and that can give, with the old nomenclature, old terminology, it can give a simple partial seizure. New name is focal aware seizure, or a temporal lobe epilepsy can have as a seizure type also complex partial seizures in new name, that's a focal impaired awareness seizure. Or even it can give you a secondarily generalized tonic-clonic seizure with a new name, focal to bilateral tonic-clonic seizure. So yes, in a patient with temporal lobe epilepsy, you can see complex partial seizures or focal impaired awareness seizures, but you can see other seizure types too.
Very good, thank you very much. We have another question from the audience that is, how different are tonic and epileptic spasms from each other?
Well, there are 2 different seizure types. Now, there's the duration. So an epileptic spasm has a duration between 0.5 seconds and 2 seconds. Now, the duration of the tonic seizure is longer, several seconds, at least 3 seconds. Now, there is a combination, which is not part of the official ILAE terminology, but you can have a seizure that starts like a spasm, and then it continues with a long tonic phase. These are the so-called tonic spasms. So there was a duration as a difference, and then there's also the gestalt, the movement pattern. So in an epileptic spasm, you have this typical movement pattern with flexion in the neck, rarely extension, but mainly flexion, and then abduction in the shoulders and also flexion in the hip. So it's both the duration and the movement pattern, and then you can keep in mind that you can have the combination of these 2 seizure types, starting with an epileptic spasm and continuing with a tonic seizure, and that's a tonic spasm.
Over to you, Simone.
Professor, we are going on with other questions. Really, we are receiving a lot of questions, so thank you for your availability. How common is it to mistake the vibratory phase with a clonic phase in a tonic seizure? And what are the EEG pattern differences?
Well, I can see quite often this error. So I can see patients referred to us to video EEG monitoring, and in the referral I can read about generalized tonic-clonic seizures, and then we make the video EEG recording, and then we can diagnose that actually this was a tonic seizure just with a vibratory phase. So it's a quite a common error that I encounter. Now, concerning the EEG correlate, well, I don't think that here the main issue is the EEG, because usually at this phase the EEG is obscured by artifacts. So it's not the EEG that helps you to differentiate tonic seizure with a vibratory phase and generalized tonic-clonic seizure, but it's the semiology. So you need to learn the movement pattern, the visual feature extraction to distinguish these two.
Thank you, Professor. Will you be able to describe again, to repeat the definition of atonic seizures and describe that in relation to the EMG findings, mentioning if they are flexors or extensors in terms of muscles?
Yes, this is a very good question. So when I answered previously the question to the placement of the EMG, I emphasized that it's very important to tailor the placement of the EMG electrodes to the semiology. Now, when it comes to atonic seizures, it's very important to examine both the extensors and the flexors. So, for example, at the neck, you put it both on the splenius capitis, so this muscle at the back of the neck that keeps the head up, and also the sternocleidomastoid muscles. So if you want to document that the head drop is because of an atonic phenomenon, then you will see the lack of activity in the flexors, and also the inhibition of the activity in the neck extensors. And then if you have more EMG channels and you would like to investigate a patient with a possible aesthetic seizure with drops, then you can opt for the quadriceps femoris and the biceps femoris muscles, of course, in addition to these the neck muscles that I just mentioned. And again, I would like to refer to the IFCN guideline paper with Margita Seik as the first author. We published there an appendix with a muscle man with a drawing that shows you where to put the surface EMG electrodes.
Thank you very much, Professor. Filomena, to you.
Yes, we have actually two questions from the same participant that I'm going to combine into one because they are related. So this participant asks, if can myoclonic-tonic seizures persist in adulthood, for example, at the age of 25 years old? And if these myoclonic seizures have the same EEG features in adulthood that you observe in children?
Right, so let me start with the first question. The short answer is yes. You can have myoclonic atonic seizures persisting also in the adulthood. So in Dose syndrome, those patients who have a genetic idiopathic cause, they usually respond better to the medication, but you can have also myoclonic atonic seizures in symptomatic patients. Now, they respond less well to the medication, and they can persist also in the adulthood. And I also have several recordings with adults having myoclonic atonic seizure. Now, the other question was if I remember well, the EEG pattern of the myoclonic seizures. Well, the most common EEG correlate for a myoclonic seizure is the polyspike. Now, you can see also spikes or sharp waves as EEG correlate for myoclonic seizure, but it's rare. And then sometimes you can't see in the running EEG, in the raw EEG signal, you cannot even see an EEG correlate to the myoclonus. And then you can use some tricks, like you use the EMG signal to trigger an averaging process. And then with using this averaging, you increase the signal to noise ratio. You suppress the background activity, you suppress the noise, and then you can record the EEG correlate. But sometimes just with naked eye, you cannot see.
Thank you very much, Simone.
Professor, another question that we received. I assume in a tonic-clonic seizure, is it the tonic or the clonic portion of the seizure that correlates with the surface EMG findings?
Well, both. So during the tonic phase, what you see is a gradual buildup of a tonic muscle activation. So the amplitude increases is very condensed. So at the normal paper speed and at the normal temporal resolution, it's just obscured baseline by this tonic signal. There's the tonic phase. Now, when the seizure continues with the clonic phase, what you see on the surface EMG signal is that longer and longer interruptions are occurring. So the tonic muscle pattern is interrupted for longer and longer silent periods, and that gives you the surface EMG pattern of the clonic phase. So both have EMG correlate. EMG will show you quite accurately what's going on there.
Thank you, Professor. I think the next one is somehow maybe even correlated. So still we're talking about EMG findings and everything. How do you differentiate a clonic seizure from an absence myoclonic seizure? And is it due to the frequency of the jerks of EMG at 3 Hertz?
So the difference between myoclonic seizure and myoclonic absence, or can you repeat the question?
The question actually is differentiate clonic seizure from absence myoclonic seizure,
yes.
But not sure I interpret correctly.
Yes. Well, clonic seizures are generalized clonic seizures are usually around 3 Hertz, and also these clonic jerks in the myoclonic absence, those are also around 3 Hertz. But it's the whole picture. It's the gestalt of it. So with myoclonic absence, you have this elevation in the shoulders, this tonic elevation in the shoulders, and superimposed on that, you have these 3 Hertz jerks. Now, during this seizure, the patient also stops with the activity that the patient was doing just before the seizure started. And then as soon as the seizure stops, they continue with the same activity. So it resembles pretty much the absence. And the EEG also shows you this 3 Hertz spike in waves.
Thank you, Professor. To you, Filomena, now.
We have a question here that it's a little vague, but it's asking, what about juvenile absence seizures?
Yes, the seizure would resemble very much what I've showed you in this child with absence seizure. So you would also see around 3 Hertz spike and slow wave, sometimes polyspike and slow wave complexes, and then the semiological hallmarks are the same. So there is a motor arrest. The patient is not responsive, and then you can have this discrete automatism. So seizure-wise, an absence in a patient with juvenile absence seizure and one with in a child with benign childhood absence epilepsy would be very similar. Yet you could have differences in the frequency of the seizure and the duration of the seizure. So in typical absence seizures in patients with childhood absence epilepsies, you would have relatively shorter duration seizures, absences, but of lots of them. So the seizure frequency would be higher.
Very good, thank you. Another question is, how can you identify the ictal onset in myoclonic-tonic-clonic seizure?
The ictal onset in a myoclonic-tonic-clonic seizure, I showed you this the seizure type and the EEG. So during the myoclonus, you've seen the bilateral synchronous, bifrontal synchronous, polyspike, and waves. So that was the EEG correlate for the myoclonic phase of this seizure. So the onset was with bilateral synchronous polyspike and waves.
I think we have time for 2 more questions. We are reaching the end of our webinar. Simone, would you like to ask the 2 last questions, please?
For sure. And again, once more, Professor, thank you very much for your availability.
My pleasure.
I think we also have another general question. So here people are asking, how can we explain focal spikes in generalized epilepsy? I think this is a general question, isn't it?
Yes. So again, there's very important that you understand this paradigm shift. So it's not as simple as generalized the whole brain and focal is just a volume in the brain. So when you say generalized, you need to know it's not the whole brain. It's bilateral big networks with rapid propagation. And then there are hubs in this network that can start the activity. So actually the triggering can be at any point in this network, but then it propagates quite rapidly within this bilateral, widely distributed network. So we also see the EEG correlates to it. So many patients with idiopathic genetic generalized epilepsy have focal features on the EEG. But then if you ask these patients about their aura, so often they would tell you also aura or other semiological findings that we normally associate with focal seizures. So indeed, in generalized epilepsy, you could have a focal start, but then there is a very rapid propagation within this bilateral network.
Thank you, Professor. Last question. Is the eyelid myoclonia triggered by any activation procedure, sleep deprivation, photic stimulation, hyperventilation?
Yes, you see these seizure types in patients with Joven's syndrome, and where when they are not medicated, so when you diagnose them and they don't, they are not yet treated with anti-epileptic drugs, they are typically photosensitive. And then they have eye closure sensitivity. So the best provocation method is photic stimulation, eye closure, and then you will see the discharge. So that's the best provocation method for myoclonic absences.
Professor, can we ask a last question? I think this is an interesting one. Yeah, myself and Filomena are continuously exchanging ideas on, oh, this is also interesting. Oh, this is also interesting. In EEG, how can we differentiate between eyelid myoclonic and epileptic discharges, spike waves over frontal regions?
So what you will see on the EEG is and actually I showed you also in the last EEG slide. So you will see a slow movement, a slow eye closure artifact, and then right after this eye closure artifact, you will see in the frontal leads the emergence of a rapid polyspike and slow wave, polyspike and slow wave, and then the frequency of this polyspike and slow wave is around 4 or 5 Hertz. Now, the eye closure is a normal eye closure artifact, which I'm sure all EEGers are familiar with. And then this bilateral synchronous polyspike and wave that cannot really be confused with any artifact, if that was the question.
Thank you very much, Professor.
Thank you very much, Professor. This was an excellent session. So I'm going to close saying that this concludes our eSeminar for today. And I would like to thank you again because your information, your presentation was just simply excellent. And I also would like to thank our audience because you had great engagement and great questions. So once you leave today's webinar, you will receive a survey on the presentation that we would appreciate if you could complete to provide us feedback. And you will also receive a follow-up email with a link to view a recording of today's webinar in just a few days. Please remember to register for part 2 of Epileptic Seizures Classification eSeminar entitled Localized Focal Seizures Using Video EEG Recordings. As mentioned before, this next webinar will take place on November the 3rd, and you can visit the NTA website at neuro-training.academy for this course and other educational opportunities. On the behalf of Natus and our Neuro Training Academy, thank you for joining us and have a great day or evening ahead of you. And we look forward to seeing you next time. Thank you very much all.
Thank you.